So let's get started with this section of the salivary gland tumors. And as you see, I'm recording this lecture offline because we weren't able to make it live. So I'm trying to stay on track and trying to keep the pace that we started with, so that we don't feel down. So we will start with the salivary gland tumors today, and let's get started. So first of all, you need to know for the salivary gland tumors, you need to know that there's a lot of stuff being asked in the boards and in the Q banks, especially when it comes to the molecular mutations in different types of salivary gland tumors and the patterns in histology and even cytology. You might end up having a fine needle aspirate for a salivary gland mass or a parotid mass, and they ask you what this is, or what's the most common molecular mutation that exists in this type of tumor. So you need to be familiar with the boardable entities of the salivary gland tumors, and make sure you have an approach. You have a key microscopic feature that you use to differentiate the different types of salivary gland tumors, and make sure you memorize all the molecular mutations and all the molecular alterations which is there in each subtype. So you will see that I pause the videos a lot of times and then continue, because I'm going part by part, so that I record a part, maybe I will go do something and then come back and record another part. So I'm trying to record it in my free time so that I end up having the lecture put together, and you'll be able to view it and see it. And then we will meet again live tomorrow at 9 p.m. and we will continue the salivary gland tumors. So first, let's get started by knowing the normal salivary glands, how it looks like. I understand that most of you guys are familiar with this. So in the salivary glands, you have the ducts, and the ducts of the salivary glands are three types. There is the interlobar duct, which exists between the lobes. It's the main duct, and then the intercalated ducts, which are there in between the acini and the striated ducts. All the ducts in the salivary gland, or most of them, is lined by cuboidal/columnar epithelium. It's usually cuboidal, as you see right here. And the duct is surrounded, of course, by the spindle, myoepithelial cell, which help in the drainage of the secretion, which exists usually inside the ducts secreted by the acini. And then in number two, you have the acini. The acini are three types or two types, and you might have a third type, which is a mix of the two, like serous, mucinous, and the third type actually is seromucinous. You have a mix of both serous and mucinous here and there. So the acini are either serous. The serous acini always have these granules, or what we call the zymogen granules, which are usually some kind of blue granules in the cytoplasm, as you see here in the picture. And then there is mucinous or mucinous acini, or mucus acini, which have the cells with clear cytoplasm, indicating mucin or clear mucin in the cytoplasm. And sometimes you have seromucinous. seeing the type of acini help you in identification of what type of gland this is. Like, for example, if you see only serous acini, so this means that you are dealing with a parotid gland. It has only serous. And if you see mucus acini only or mucinous acini only, so you're dealing with a sublingual. And if you see seromucinous, which means that you see both, you see serous and you see mucinous as well. So this means that you're dealing with a submandibular. And for you to remember, submandibular SM is seromucinous with the SM. So that you remember the sublingual is mucus and parotid is always serous. Each acinus is composed of secretory cells or secretory epithelium and myoepithelium. The secretory epithelium is the cuboidal epithelium, which secrete the secretions in the lumen of the acinus, and you have the myoepithelial cells, which contract and help in the drainage of the acinar secretions. So ducts, acini, and then you might have some fat, which is labeled as number 3. Here in the picture, you can see the fat right there surrounding the acini, which is in this picture serous acini, and as you see the ducts. Also, you might see some lymph nodes. Sometimes there is some associated lymph nodes or intrasalivary gland lymph nodes, which might exist inside the salivary gland itself, especially in the parotid gland. The gland itself may be within a benign lymph node tissue, and you might see benign lymph node tissue here or there, or even inside the glandular tissue itself. So be prepared if you see some lymphoid follicles here and there in a salivary gland. That's fairly normal, especially if the lymph nodes or if the lymph node architecture looks normal. So in this section or in this lecture, we will focus on the malignant tumors and benign tumors, which are masses of the salivary glands, benign and malignant masses of the salivary, benign and malignant tumors of the salivary gland. And we need to have the broad classification, which is the broad microscopic approach. So that I give you an introduction. So I wouldn't say a tumor. I would say if you have a salivary gland mass and you're looking under the microscope, you need at first to see what is the predominant cell type that you see in the slide or under the microscope. Are you seeing oncocytic cells? And of course, everyone knows what oncocytic cell is. This means that you are having mostly rounded cell with abundant granular cytoplasm, abundant granular eosinophilic cytoplasm, and rounded nucleus, sometimes prominent nucleolus. It depends, but this is how oncocytic cell look like. Rounded, with a rounded nucleus and granular eosinophilic cytoplasm. That's oncocytic. And the second pattern or the second type of cells that you might be seeing is basaloid. Basaloid means that you see blue cells. Basaloid is blue. Basaloid is blue. So you're seeing blue cells. That's basaloid. Or are you seeing spindle cells? You see any spindle cells? Spindle cells might be pleomorphic adenoma and its mimics. That's spindle cells. Or do you see clear cells, or do you see a high-grade tumor? High-grade tumor means extremely pleomorphic cells. That's a high-grade entity. So oncocytic, basaloid, spindle clear, and high-grade. What we will cover today in this lecture is the oncocytic, and hopefully I will start covering the basaloid, and then we will cover the remaining in our live session for tomorrow. So let's start with the oncocytic pattern. So in the oncocytic, as we mentioned, we are seeing pink cells, cells with abundant granular eosinophilic cytoplasm, And the reason why the cytoplasm is granular and eosinophilic is that it has abundant mitochondria, which stains pink, and it's usually granular, and that's why you have granular pink cytoplasm. Often the cell is big, polygonal, with well-defined border, granular cytoplasm, rounded nucleus, and prominent nucleolus. We already described this a moment ago. Please take care. Before jumping in to diagnose an oncocytic lesion or saying that this is oncocytoma or oncocytic carcinoma or whatsoever, please take care whether you see the oncocytic cells everywhere in the lesion and everywhere in the mass, or is it just an isolated component? Because if you see oncocytic cells which are here and there, they are isolated here and there, that's oncocytic metaplasia or oncocytic hyperplasia. It's not an oncocytic tumor. An oncocytic tumor should have oncocytic cells all over to call it oncocytic tumor. So take care, put in the back of your mind that you have oncocytic metaplasia, oncocytic hyperplasia, which might confuse you with an oncocytic mass or an oncocytic lesion. The differential is oncocytic metaplasia, oncocytic hyperplasia. You'll see isolated oncocytic cells here and there. You don't see an entire mass which has oncocytes or showing oncocytic cells. So let's get started with the first couple of oncocytic lesions that we have. So starting with this couple of masses and couple of tumors. So here come my color coding. So I will give you this modified notes in which I color coded the information in the notes. So you will see that the microscopic features I highlight in yellow, and then the additional information that you need to know I highlighted in pink, and the characteristic IHC and the characteristic molecular mutation I will highlight in green. That's our color coding for the salivary gland to help your eye navigate in the revision. When you try to cover the salivary gland tumor by your eyes, you have the color coding so you are able to maybe revise one time, go over the microscopic facts, and then another time you go over the key molecular and IHC for each entity. Whatever you need, it's easy for you. So the first entity is oncocytoma / oncocytic carcinoma. In both of these tumors, you would just see proliferation of oncocytes. The classic oncocytes that I was talking to you about, you will see that it's occupying the whole mass. It's occupying the whole tumor. What differentiates whether this is oncocytoma or oncocytic carcinoma is the malignant features. Presence versus absence of malignant features. So if there is no pleomorphism, no mitosis, no invasion of the surrounding glandular tissue, so the lesion is well circumscribed, well capsulated, the cells looks benign, no pleomorphism, no mitosis, nothing, that's oncocytoma. And it usually happens in the parotid gland, as you see here. However, if you see pleomorphism, mitosis, invasion to the point that the mass might be encapsulated or not be capsulated, of the capsule, you feel like the mass is sending out invasion in the surrounding glandular tissue. That's when you start calling or suspecting oncocytic carcinoma, which is rare, by the way. Usually most of the patients would have oncocytoma rather than having oncocytic carcinoma. That's the first entity. Very easy and very catchy for the eye. The other entity that I feel very comfortable with, and it's very catchy also for the eye, is the Warthin tumor. In the Warthin tumor, you will see the triad. The triad is mature lymphoid tissue. You will see here. and then you will see double layer of oncocytic cells or double layer of oncocytes, and you will see that there is a kind of irregular jagged and papillary growth. What I mean by papillary growth is that you won't see like a solid mass. You will see that there is a kind of fingers, thick finger-like papillary projections. That's the papillary growth. But the two key features that you need to memorize and put a star on are the lymphoid tissue, the mature lymphoid tissue, and the double layer of oncocytes surrounding this mature lymphoid tissue. From when they saw this tumor and saw that there is a lot of lymphocytes in the tumor tissue and there is mature lymphoid tissue there, which look very benign though. So they thought that this tumor could be a transformation of salivary gland tissue entrapped in a lymph node. Like there was a lymph node and there was some salivary gland tissue entrapped inside this lymph node, and then there was an oncocytic transformation of this salivary gland tissue. So now you see the lymphoid tissue of the lymph node and the transformed salivary gland tissue surrounding. And that's how you end up seeing this pattern. So that's why they're saying this likely developed from a transformation of salivary gland tissue entrapped in a lymph node. It also happened in the parotid gland. And the two things that you need to memorize, that it's highly, highly related to smoking and on fine needle aspiration. We will cover this once more in cytology. On fine needle aspiration, the Warthin tumor, when you aspirate, you will see that there is a kind of a motor oil aspirate fluid. The fluid will look like motor oil. So just remember that you have the word war, and always the war needs oil. The war needs oil, the oil for the war. So war needs oil. So Warthin tumor, motor oil, so that you memorize this. And you might also remember that the war produced a lot of smoke, and that's why it's related to smoking. And that's why I memorized it. It's highly related to smoking, and it shows motor oil on fine needle aspiration. Double layer of oncocytes and lymphoid tissue or mature lymphoid tissue in the middle or in the center. The next entity is secretory carcinoma. And as you see here, I highlighted the molecular mutation, which is the ETV-NTRK. ETV6-NTRK is present in a lot of tumors. And before you enter your boards, you will definitely collect them in one place. Like say, these are the tumors which are ETV-NTRK positive, showing ETV-NTRK mutation. So it's ETV-NTRK. I always remember this by the TV and the TRK, which stand for Turkey. So I say this is the Turkish television or the Turkish TV, the ETV-NTRK, so that I help you memorize the gene and I help you memorize the mutation. That's the secretory carcinoma. What's secretory carcinoma? You always see the same oncocytes. Well, you will see the same eosinophilic granular to vacuolated cytoplasm cells. However, this time, the cells are not forming any solid masses like the oncocytoma, and they are not rimming around lymphoid or mature lymphoid tissue like in Warthin tumor. Instead, they are making some kind of tubular structures. See these tubular structures? Here is a lumen here, and here is a lumen there, and here is a huge, big lumen here. And inside this lumen, here is the key. Inside this lumen, you will see eosinophilic secretion inside the lumen. This is what I highlighted. Eosinophilic secretions in lumina. So you have the same oncocytes, but remember the word secretory. This reminds you of secretion. So this reminds you of acini or tubules. That's why the oncocytes here are making tubular structures. mainly, or making some kind of cystic structures, cysts. And in the cavities of these cysts or these tubules, you'll find this structureless eosinophilic secretion in the lumina. There is no zymogens because the zymogen is a characteristic of acinic carcinoma, as we will mention later. And for the immunos, this tumor is characteristically positive for S100. Remember this. It's positive for S100 and positive for hemoglobin. Actually, you have the exact same carcinoma in the breast. There is secretory carcinoma of the breast, and it's also positive for S100 and hemoglobin, and has the exact same eosinophilic secretions in the lumen, by the way, if you want to associate. See, they are saying formerly it used to be called mammary analog secretory carcinoma. This is a carcinoma that's malignant, but it's very indolent, it's very benignish. Doesn't metastasize, so it's relatively benign. Then we have the intraduct carcinoma. Intraduct carcinoma is like a DCIS. It's like a duct carcinoma in situ, but in the salivary gland, duct, not in the breast ducts. So it's DCIS. See, it's this exact same DCIS pattern that you will see in the breast, in which there is proliferation of the ductal epithelium with formation of some kind of microlumens. See, these microlumens, due to the bridging of the proliferated epithelium, the proliferated epithelium are kind of making bridges, and it has this microlumens in the, as you see right here, or as you appreciate here. So the intraduct carcinoma of the salivary glands is like the DCIS of the breast, but it's actually in the parotid, not in the breast. Just to collect, just for you to collect. You will see that there is a rule that applies to all the oncocytic lesions, because we are now done with the oncocytic lesions, by the way. So all of them usually happen in the parotid in terms of the site. All of them usually happen in the parotid. You have 4 characteristic patterns, which is either solid oncocytes, that's oncocytoma / carcinoma, and you have the lymphoid tissue surrounded by 2 layers of oncocytes, that's Warthin tumor. And you have the oncocytes making lumens. Lumens could be tubules, could be cysts, and these tubules and cysts are filled with eosinophilic secretions. That's the secretory carcinoma. And finally, you have the DCIS-like proliferation of the duct epithelium with formation of microlumens, and that's the intraductal carcinoma of the salivary glands. So now we'll move on to the basaloid, or to the basaloid pattern. So I just figured out that I kind of forgot my USMLE logo, I think, right there. It was right there. That's a good thing about the live. You guys will just like notify me. Oh, there is a logo up there that you need to. That's a USMLE logo. This is not USMLE stuff. Well, but you know, that's my other passion, because I explain USMLE, so that's so that's the logo that I put in most of the videos that I record for the USMLE exam preparation and the strategies and these kind of things on my YouTube channel for the USMLE. Anyway, so we were talking about the basaloid. Basaloid means blue. As I mentioned before, that's just basaloid. That's what basaloid means. So the first entity is the basal cell adenoma / basal cell adenocarcinoma. It's the same thing like oncocytoma, oncocytic carcinoma. That's the same thing. So basal cell adenoma, or they call it sometimes monomorphic adenoma, and the basal cell adenocarcinoma. So the key thing that I always use to memorize the basal cell adenoma is having this basement membrane-like material in the periphery. So see, you're seeing some kind of perpendicular blue cells. See, perpendicular basal cells. Here they are, like these ones. Perpendicular basal cells, and they are resting on a basement membrane-like material surrounding the nests of these blue cells, with some kind of also basement membrane-like material in the middle. I believe these are the others which were sectioned like transversely, and these are the basement membrane material which was sectioned longitudinally. I believe so. That's why you end up having this flavor of basement membrane-like material and this flavor of basement membrane-like material. It's kind of difference in how you section it, I think. But you're having basement membrane-like material and perpendicular basal cells or blue cells, and they call it monomorphic adenoma because the key difference between this type of tumor and the pleomorphic adenoma. So we have the pleomorphic adenoma on the other hand, which has the exact same thing, which is the epithelial component, but it has also spindle cell component and like spindle cells and other components, which may be cartilage, maybe bone. That's why they call it pleomorphic adenoma. But this has only the epithelial component or the cellular component, the epithelial component of the pleomorphic adenoma. That's why they call it monomorphic adenoma. But I always remember it as basal cell adenoma, and this is how it comes actually in the questions, in the boards, or in the Q banks. They always put it in the choices as basal cell adenoma. So to remember basal cell adenoma, basement membrane-like material, and basal cells or basaloid cells or blue cells. They're perpendicular to this basement membrane-like material. You need to remember the mutation. He didn't write it down here, but he wrote it down in the collection table at the end. So at the end of the notes, he wrote a collection table with all the mutations and the tumor entities which have these mutations. So the basal cell adenoma or monomorphic adenoma, it's positive for CTTN and cyclin D mutation. CTTN and cyclin D mutation. Not so important, I didn't see it asked in the questions, but I'm letting you know. What's the difference between adenoma and carcinoma? You tell me. Very easy. Mitosis, necrosis, invasion. The same three exact words that we said in the oncocytic adenoma versus oncocytic carcinoma. All right. Then the other basaloid is polymorphous carcinoma. And that's the P's. Polymorphous carcinoma. It shows PNI. What's PNI? Perineural invasion. The first tumor, which is painful. Painful because it infiltrates the nerves. And it might end up infiltrating a sensory nerve, and that's why it leads to pain. So it's a painful tumor. It might lead to neural invasion and perineural invasion. PNI. So polymorphous PNI. It infiltrates locally and usually show perineural invasion. So this means that it's malignant. It makes sense. The second P is PRKD, which is protein kinase D, I believe, which PRKD fusion or mutation. That's the second P. So PNI, PRKD. The third P is palate. It usually happens in the palate, in the minor salivary glands, especially those of the palate. So they tell you that this patient is having a palate mass or a mass in his palate, and they took a biopsy out of it, or they took a representative section out of it. So before you look, prepare your mind that you might end up looking at polymorphous carcinoma, palate, PRKD, PNI, polymorphous carcinoma. It's a carcinoma, it's malignant, it infiltrates the nerves, PNI. You need to remember that this is the second tumor which showed diffuse strong staining with S100. And it's also monomorphic. It's formed of some blue cells, basaloid cells, blue cells forming regular tubules. That's why I always say it's a very simple tumor, forms some basaloid cells, blue cells, making some lumens and making some tubules. That's it. That's polymorphous carcinoma. So it's uniform cells or monomorphic cells showing diffuse staining of S100. They call it polymorphous because it might come in a lot of patterns and a lot of shapes. You might see some Horley patterns, you might see some tubular pattern, you might see concentric layering pattern. It come in a lot of flavors, but most likely in the boards, in the pictures, in the Q banks, it come in as tubules. And they usually tell you that the mass is from the palate for some reason. Very frequently asked in Path Dojo Q bank. That's polymorphous carcinoma. So polymorphous, PNI, PRKD fusion, and palate, minor salivary glands. And it's basaloid with a B as well. Diffuse strong staining for S100, remember this. Canalicular carcinoma, the next entity. Canalicular carcinoma, you see blue cells, the blue cells make canals. You know, it's like when you in geography, when you draw a canal, you draw it like this. It's like branching canal. It's canalicular. So it's like canals of blue cells. And these canals are anastomosing. These blue cells are making anastomosing canals. That I always say, like, it's like anastomosing sea or anastomosing lakes of blue cells. See, like as if you're seeing lakes of blue cells which are anastomosing together. Okay, and the key also that make you confirm your diagnosis is the stroma. The stroma surrounding these canals of blue cells is always loose fibrillar stroma. You see fibrils. You see fibrils. Can you see these fibrils in the stroma? So it's loose fibrillary stroma. So you see the anastomosing canals of blue cells with loose fibrillary stroma in between, canalicular patterns, cords and ribbons of interconnecting basaloid tumor cells with loose fibrous stroma in between. This is also come in minor salivary glands, which are the salivary glands in the upper lip. You know, is almost always in the upper lip. Almost always means that's the key word. They will tell you an upper lip mass or a mass coming from the upper lip. Well, okay, makes sense. So I'm preparing my mind that I will see the canals of blue cells and the loose fibrillary stroma in the background. Well, that's it, canalicular carcinoma. It's benign tumor. I never see it in questions a lot, just maybe only once in one Q bank out of the 3. So it's not so important, I believe. However, polymorphism is, wow, very, very common. Acinar or acinic cell carcinoma, oh, I didn't highlight. Okay, let me highlight and then continue the recording. Lastly, the acinic cell carcinoma, as I mentioned. And as you see, I highlighted all the information. So the key microscopic feature here is seeing the acinar cells. And to say that these are acinar cells, you need to see the zymogen granules. Please memorize this like your name. That's by heart. Basophilic granular cytoplasm. See the cytoplasmic granules, the basophilic cytoplasmic granules here, there, and there, and here. These are the basophilic cytoplasmic granules, and they are called these zymogens. That's very important to call acinic cell carcinoma. So you'll see just acinar cells all over the place with the characteristic basophilic granular cytoplasm. And that's why, although these cells doesn't look very blue, they don't look as blue as the other basaloids, you know. However, they called it basaloid so that you memorize that it has basophilic granules in the cytoplasm or basophilic granular cytoplasm. That's the zymogens. The zymogen granules stains by PASD And that's very important. It's a classic tumor. It happened in the parotid. Sometimes you see some background lymphoid infiltrate. I didn't see it in all the pictures that came in the questions. I just used to rely on the basophilic granules in the cytoplasm. See, I always say the basophilic granular tumor. I always say this. It's a basophilic granular tumor. The tumor with basophilic granules. And some kind of blue roundish nuclei with prominent nucleoli. You need to remember this translocation, very important, very, very important, NR4A3 or NR4. At least you need to remember the first three, the first part, so that you can spot it in the choices. If they ask you which mutation is this tumor famous for, so it's NR4, NR4A3 translocation. That's the most common, and this tumor is positive for dog1 and SOX10. Dog1, SOX10, dog1, SOX10. So dog, SOX, okay? Dog, SOX. So acinar or acinic cell carcinoma, you have the acinar cells. The acinar cells have this characteristic basophilic granular cytoplasm, and it happened in the parotid with sometimes some background lymphoid infiltrate. NR4A3 translocation, dog1 SOX10. This tumor is malignant, but it's not very aggressive. It's very, very common in questions in the boards. So you need to make sure that you memorize it by heart. Okay, we will stop right there, and we will continue tomorrow live at 9 p.m. Eastern Time. We will continue the remaining basaloid tumors, and I will finish the spindle, the clear cells, and the high grades. So we have only 4 pages remaining. We finished 4 pages, and we have 4 remaining pages because this notes run until page 8, then 9, 10, 11, 12 are just collections. You're just collecting the patterns, collecting some useful tables, and collecting the molecular mutations in one table. So these collections, you'll just go through by yourself. However, we have only 4 pages remaining out of 8. All right, thank you very much, and see you tomorrow live at 9 p.m. Eastern Time. Thank you very much. Enjoy the rest of your day.